I think the numbers joining us are slowing down. So I'm very conscious we've got quite a packed agenda this morning, so we're going to get underway. For those who don't know me, I'm Helen Northmore. I'm the Head of Digital and AI at the Life Sciences Hub. I'm responsible for the digital health ecosystem for Wales. And I know that we're being joined today by people who haven't been to an ecosystem event before. So just very briefly wanted to welcome you and point out sort of some places you can go and find out more about what we do. So if you'd like to follow us on Twitter, we're on @DHE Wales, and that's a really good source of information about exciting digital projects in Wales, work we're doing, events that are going on in the sector, reports, funding, opportunities, all sorts of information we transmit through Twitter. We also have a website, digitalhealth.wales, and we'd really recommend that you spend some time there. It's the home of a number of national programmes, including the ecosystem, technology-enabled care, information on the national data resource, and Care Home Cymru. Also has a wide range of resources, self-serve information, links, signposting, so you can find out lots of information and queries. Also a large amount of information about projects that we've done and things that we've learned. So please do feel free to check out our website. If you've got any questions about what we do, please feel free to email us at digital@lshubwales.com. So as we said, we do a series of events throughout the year and we try and pick interesting topics. And one of the things that was coming out to us was that there were a number of organisations within Wales looking at digital strategies. So we felt that we wanted to give an opportunity for those organisations to talk about what they're doing. And we're delighted so many of you have joined us today to hear about that. And I'm going to hand over now to our chair of the event. So Bob Hudson is the newly appointed interim chair of Digital Health and Care Wales. So I think has officially been in post a whole 2 weeks today. And Bob will take you through today's event. Welcome, Bob.
Thank you, Helen, and Croeso Barada. Good morning and welcome, everybody. I can see the numbers for the event are continuing to increase in the sidebar, so we've got a really good audience today. You're all very welcome along to this event. As Helen said, I'm Bob Hudson, the interim chair for Digital Health and Care Wales. I was appointed back in November to oversee the organisation through the transition to the go live on the 1st of April. And after I've done a few introductory slides in terms of housekeeping rules and so on for the day, I'll just say a couple of words more about DHCW before I move us into the rest of the event during the day. I mean, this is a really important event. I think the digital health ecosystem has been set up as a collaboration between the Life Sciences Hub and what was the NHS Wales Informatics Service, NWIS, and as of 1st of April, Digital Health and Care Wales. And the aim of that collaboration is about opening up Wales systems and data to developers, bringing stakeholders together to share development and best practice, and that's exactly what we want to do today. If I could just kick off, though, with a couple of housekeeping slides. Few simple rules that we would ask you to follow during the course of the event to make sure everything runs smoothly. So firstly, please mute your microphone and keep your camera off throughout the event. We want to encourage questions. So if you've got questions or comment, can you use the Teams chat to post those? And we've got a Q&A session for about 30 minutes at the end of the event today. So we will try and come back and answer as many of those as is possible. But if you could use the chat responsibly in the sense of just sort of keeping the chat to specific questions, otherwise it will be difficult for us to filter those out as we will need to. The intention is that there will be a break in the proceedings at 10:55 for about 15 minutes, and also for people to note that the session is recorded, will be put online after the event, but all names will be obfuscated, I think is the correct word.
Just one question, one comment, Bob. We have a question from Alan Smith. He's raised his hand.
Oh, sorry. Okay. I don't think I haven't got anything. Bear with me.
Oh no, they don't. Sorry, they apologise.
I don't think so. Yeah, that's okay. Okay. At various points during the course of the event, we'll be posing some questions to you, and we'll be using, I think, particularly for our third talk of the day with Stephen, Mentimeter, and you can see the connection information there in terms of the web address www.menti.com and the code that you would need, or the QR code on your mobile phone if you want to take part in those questions. They will come back later in the day, and we'll be showing the result of the polls during that session. Okay. So our agenda today is, as I say, initially a few further opening remarks from myself. We have three speakers. I'm going to hand over first of all to Dr. Allan Wardhaugh, who's the Chief Clinical Information Officer at Cardiff and the Vale University Health Board, followed by Andy Haywood, Director of Digital Services for the Welsh Ambulance Services Trust. And after our break, Stephen Frith, who is the Programme Director for Digital Services for Patients and the Public, before we move into the final Q&A session. Okay, in terms of, that's the sort of the broad outline for the event today. In terms of just a couple of opening comments from me, as I've said, I am have been appointed as the interim chair for Digital Health and Care Wales. And I suppose the timing of today's event is fantastic in that sense. As Helen said, we came into being literally on the 1st of April, just a couple of weeks ago today, when we had our first board meeting. And DHCW, as a key partner in the ecosystem, our aims are to support the NHS and widen the partners to develop digital systems that improve services to patients and clinicians, crucially that impact on wider health goals, including reducing inequality, improving health and well-being. And our aim is to build on the legacy of NWIS. But it's important for me, I suppose, to stress that this is more than a rebranding or just a redesignation of an organisation that you'll all be familiar with. The new Special Health Authority has a different legal status. It does have transparent governance in terms of meeting in public. We have a new financial settlement, which is very welcome. And crucially, we have a wider remit. And that wider remit includes looking beyond the boundaries just of health into care defined in the broadest sense in terms of working with partners who impact on those broader system goals that I've just talked about, like health inequalities and improving health and well-being. And also importantly, I think a contribution to the economic development of Wales. And I think that's something that the digital ecosystem idea is central to, and we want to play our part in that. I think crucially, the new organisation puts digital at the top table in the NHS Wales. It's not been there before. And DHCW will be expected to offer system leadership in an appropriate way, but also to be a trusted partner with all NHS organisations and other key stakeholders. It's our job to tackle issues with legacy systems, and we have many of those, and to move the organisation towards a different future based upon open systems and data, and I think a strongly user-centred model of design and organisational working. So we come into being at a time of unprecedented change. It's difficult to overstate that. And I think the last 12 months has demonstrated just what can be accomplished when there is an overriding sense of need and when real collaboration happens across the system, as indeed it's done. So you look at things like the rollout of new systems, supporting test, trace, isolate, supporting the biggest vaccination program we've ever seen, enabling clinicians anywhere and everywhere to have access to the summary clinical record, virtual consultations, in hospitals, working for clinician office-based staff. Just a few examples of the things that have been done to sort of shift the system over the last 12 months. And in a sense, that brings us back to the purpose of today in terms of hearing from our speakers about the digital strategies and programs in a number of NHS organisations in Wales. I'm going to hand over to Andy now for the next 20 minutes, Andy Haywood. Director of Digital for the Welsh Ambulance Services Trust, who's going to talk to us about the development of WAST strategy. And then, as we said earlier, we will pause for a break in about 20 minutes, 10:55 to 11:10, come back for the third presentation and take questions at the end. And I can see that there's a few questions beginning to come through in the chat, so please feel free to do that. So without further ado, I shall hand over to Andy Hayward.
Thanks very much, Bob, and yeah, beat the timing on that. Thank you, Alan, for setting the bar there. I'm Andy Hayward. I'm the Director of Digital Services for the Welsh Ambulance Services Trust. I joined the organisation in January last year as the first exec lead for digital, and then obviously the COVID pandemic kicked in, and this strategy was published in November of last year. So I'd just like to take you through kind of how we got to the principles and some of the key ways that we structured the strategy, but also why we're doing it in the first place. But before I get into that, I'd just like to take you through who we are as the Welsh Ambulance Service, because it might not be fully apparent. So we're a national service that covers the entire population of Wales and anybody who visits during the summer months or tourists, etc. We cover the full 8,000 square miles of the country from the top of Snowdon all the way through to the centre of Cardiff. We've got around about 3,500 staff, although that's growing at the moment, with a lot of those largely remote, working within ambulances or out amongst the country. We've got 113 buildings, and this is from last year's annual report, 778 vehicles, of which that number is now increasing, and they're used for a variety of reasons. So how do we use all that? So again, from last year's annual report, so these figures will be higher this year. We attended just under 500,000 verified incidents. So these are kind of blue light emergency response, 1.2 million phone calls between 111, NHS Direct Wales and the 999 system. We facilitated 670,000 non-emergency patient transport journeys, and we had over 6 million interactions with our 111.wales website. So the services we cover, looking at the point at which you click to begin with on the 111 Wales website to look through your symptoms, see what's available. We cover the phone lines that you'll ring after that, the response that you'll get if it's blue light, and then the non-emergency transfer as you get to your elective care at the end of it. So as you can see, the scope of the services we provide across the country is huge. It's very broad. And then when you're looking at a new inaugural digital strategy, it kind of begs, if digital is the answer to all that, what's the question? Why do we need a strategy in the first place? And really, what's the purpose of it? What do we want people to know when they pick that up? And why should we compel them to read it? So the three questions we came down to in terms of boiling it simplistically were, how are we going to react to change that comes our way? How do we want to drive the change that we want as an ambulance service? And then how do we go around the practicality of delivering that change? And like Alan said earlier, this is a journey. It's not necessarily, and it's something that we need to come back and continue to review. So within the strategy, and make sure that you get a link to it if you want to read the detail behind it, we started by setting the scene, so looking at who it's for, and broadly three groups. So the patients, the people of Wales, our people in terms of staff, and then the broader system, which is encompasses NHS Wales, but also community, third sector, local government, and all the different interactions that we have with people like the police and the fire services as well. We then looked at the shifting landscape that we're delivering in, so the changes that are coming our way. You've got the standard kind of managing successful programs of political, economical, societal, etc. Obviously, we've seen a huge shift in that in terms of the recent pandemic, but also technologically what's changing in that space, because some things may happen which we don't have control of in terms of advances in AI or other technologies that we need to be capable of dealing with. We also looked at existing plans, commitment and strategy. So that's not just within the Welsh Ambulance Service. We've got a 10-year strategy known as Delivering Excellence, which looks at what we want to do as an organisation, but also within the UK, within Wales, what's the existing work that's being done? So we talked about WACTA, there's the Darzi review, there's the Carter review, there's the Healthier Wales publication that was put out a couple of years ago, there's the establishment of Digital Health and Care Wales, and then the National Clinical Framework, to name but a few. So there's a lot going on that we can plug into and kind of find our way within. But ultimately what this comes down to is a huge amount of change and complexity in the system, and actually when we're trying to put a strategy out there that everybody can understand, we need to boil that down to something that's really simple and that we can explain within 2 minutes and a whiteboard if we really need to. So what we did for that through a large amount of engagement was to come up with a few sections to look at how we react to change, how we drive it, and then how we're going to deliver it. And the first part of that was to look at 5 digital principles. We went for 5 because you could count it off on the fingers of your hand. And ideally, this is that it works at different levels and everybody is able to remember these principles, and eventually we can start to build them into things like our spend control process. So these are the things that you're going to apply when you think about a change that's coming your way and something you're going to do with technology. So if somebody comes to sell you an app, or you decide that you want to do something with a new technology, you think about these things when you go forward. So there's more detail within the paper, but I'll just go through the high level. So the first one of these, it comes back to what we all know is one of the key things we need to think about, which is user needs. So empower all our users to do more of what's needed. So we need to think about, and whilst it seems simplistic, actually, this is really important when you get to sort of new technology and some of the stuff that Alan was talking about in terms of AI, machine learning, where it can seem as a solution in itself. So who's this for? What cohort of people? Is it for the patient? Is it for staff? And what is the need that they've articulated that this thing addresses? How are we going to address that need? And have we checked with the user that that does what they want? And this has particularly been born out of my experience talking to one of my previous bosses, Rob Shaw at NHS Digital, who's the Deputy Chief Exec, used to talk about a session at Government Digital Services with a pensioner who was running through the Renew Your Car Tax disc page on the website, and the team spent a full day with this lady moving things around, changing the colour of the fonts, changing the process flow about how to renew tax disc. At the end of it, she was very happy with it, and they asked, would you use it? And she said, absolutely not. I go down to the post office and that's the way I do it, and that's how I renew my tax disc. So, remembering what the need is and the people you're trying to interact with, and working out what they want and talking to them about it. And then eventually, as we get further along, can I empower the user to service this need themselves? Because ultimately, a lot of research in terms of EHR delivery and other key areas shows that when people feel empowered to use the technology, they feel like they're being included in the process and have been included in the process to develop it. They're much more likely to adopt it and deliver benefit from it. So that's the first one. And again, as I say, there are layers of detail beneath this, but this is hopefully so that anybody can pick this up and understand at a basic level what they need to think about wherever they are within the organisation. The next one, again, hugely important, is ensuring access for people. So, a classic, do people know that this piece of technology exists? We can have a fantastic program to deliver it, but if we don't do the communications to let people know it's there, how to use it, then again, we're not going to deliver the benefit because it's not going to be used. Have we given people the training information required to use it properly? So again, when people are starting to plan this out, if they're within another directorate, have they thought about that? Have they thought about the comms plan? Have they thought about what training is going to be required, who's going to deliver it, and how we're going to take people out of their day job to do it? Have I considered the accessibility requirements of everybody, which could include, beyond things, sort of sensory loss and other areas like that, could also include language. It can also include the fact that some people won't use digital technology, and we need to remain that needs to remain a consideration. So whenever we're thinking about something new that's going to provide a service, if there is a non-digital element, we need to consider that as part of the plan and work out how we're still going to ingest the data from that and make sure it's all part of the same system. And then finally, does it work on the devices and services that my users understand? So, again, this is about engaging with the user about, what is the platform they use? What is the service they use? If we're talking about, web access on the front end, and we're looking for a particular demographic of people, are we looking at TikTok? Are we looking at a different area that these people are going to use rather than trying to force a change upon them? Respect and deliver value from our data. So again, this is looking at user need when we're talking about data, looking at data quality, which everybody will understand, making sure that it's presented in a manner that people can understand it as well. So, have we gone back and made sure that this is actually usable by people? Are they going to derive benefit from it? And then ultimately, who owns that data, and do we have the consent to share it? Now, again, we'll know there are layers of detail beneath that, but that's critical for anybody to understand if they're thinking about buying a new app or service within the organisation. And again, it comes back to this point that we want to eventually devolve these things out to people to allow them to innovate. So we need these principles to guide them as we move forward. or Wales, or Once for Wales as it's been called as well. Now this is really important. So I'm relatively new to the Welsh Health and Care system, but whenever you have a good idea, if you do enough digging around, enough talking to people, generally there's somebody within the country that's already on with it, or there's a national programme that's delivering it, like the National Data Resource or Digital Services for Patients and Public. So we need to think about this in a number of different lenses. So if we're developing something new and it's innovative and it's helpful and it's a benefit, who else could benefit from that, you know, even with a tweak or a slight change? And have we shared that with people? Have we done our bit for the wider system? Will what we're doing operate with other systems, and will it continue to do that in the future? So, you know, if we're going to the next level of detail, is when we're looking at APIs, are they FHIR HL7 compliant? If we're talking about patient records, etc. If we're talking about clinical terminology, we're aligning with SNOMED or other things like that. So we considered what the national position is on policies and standards and made sure that we align with it. The other thing is as well, obviously, we know the point of interoperability is it gives you increased capability by making those systems work together. Rather than going for one monolithic entity that does everything, a nest of different systems that work together seamlessly can often be a better tool. And then finally, to what I said at the start, you know, does this similar capability exist elsewhere in Wales? So let's not duplicate effort. If there is a national programme that's doing something with this, let's get involved as a pilot or wherever else, and let's deliver as part of that with the rest of the system, because that's where we're going to deliver the most benefit. We're not there as a single organisation. And then deliver sustainable change. Now, within our team, that's often, have you spoken to IT about it? But there's much more beyond that, which is, you know, who's going to be responsible for this product or service once it's delivered? You know, the program to get it live is the first bit, but the actual delivery is the point post go live, and that's when the benefit starts to be derived. So what's the service management arrangement for this piece of kit? Who's going to understand it? Who's going to manage the contract? And ultimately, who's going to iterate it over the lifespan of it to make sure that it remains aligned with user need and what the service needs as well. Internally, does the ambulance service have enough people or capability to support that service once it's live? You know, and that may involve clinicians, it may involve communications people, it might not just be technical people. How does the product or service affect the technology that we have? So again, this is partly for other directorates and the people as they think about bringing new technology in. You know, have they considered or spoken to the central team to make sure that the data is going to flow effectively, that it's compliant in the way it needs to be, but also, you know, have we got the server space for it? If it's going to be cloud, can we network it effectively? And then have I considered the risks of failure and planned how to mitigate them? Now, the big thing around that is when you're looking at things like robotic process automation or other things, is, you know, you're rapidly going to build a reliance on some of these things. And have you really thought about what will happen if they go wrong? If you think about flow control that National Air Traffic Services use with Europe, humans can't do that job anymore. So if that particular system drops, then it limits the flow of air traffic across Europe. So if we're going to do similar sort of things in terms of automation, we need to be really clear about how reliant we're going to be on those systems and make sure our backups are aligned and funded effectively. So those are how we're going to react to change. The change we want to drive, we put into 4 digital missions. So these are a set of 4 outcomes based around what we're going to do for the patient, what we're going to do for our workforce around their digital workplace, what we're going to do around data, and then the foundations that sits underneath it all with the patient at the top. And we align these around a series of outcomes that we went with people, and there's a lot more detail within the paper. But, you know, patients will have all the skills, information and tools required to manage their own care, but know exactly where to go for help and what to expect when that's no longer possible. So this is something that we can track against with all our things like our electronic patient record coming later this year, to say actually year on year, are we getting closer to that outcome and what are we doing to get there? Within our digital workplace, again, I say we've got a largely remote workforce, so our people have got training tools and information required to perform their job to the highest level, anywhere, anytime, from any device. So, you know, a true digital workplace. And obviously COVID with working from home, etc., has really kind of brought that into sharp relief. Intelligence through data, so the best data, best time, presented in the best manner to drive the best decision. Again, really speaks for itself, but it's just there as a marker in the sand for people to remind that the data is useless if we're not using it effectively and we're not communicating it properly. And then digital foundations about a flexible, scalable, resilient infrastructure fit to carry our ambition. So ultimately, you know, looking at the triangle, if we don't get this right, we're going to start to, we can have the greatest idea in the world, but we're going to get into this kind of area where actually, if you don't get that right, then you're going to lose the buy-in from the organization and the whole digital transformation strategy in itself is going to fall over. So we've structured that around, we've got the missions, the visions that I've just gone through. There are a set of objectives in the strategy that we're going to review on an annual basis, and then that's how we're going to measure our success based on the outcome, rather than, you know, have we implemented the technology. It's more about how we're using it and what value have we derived from that. And then finally, we've got 3 phases of delivery. So these are, the first one is to stabilize, so making sure that we've remediated any existing risks that we've got, that we fully understand where we're at, that we've invested properly in the team, whilst also designing the operating model that we need for the future in terms of the strategic ambition of the Welsh Ambulance Service and for what Wales wants to do with our services. Also looking at rapid pilots for those missions. Then the optimised phases, as we start to move towards that new operating model, new digital governance, and start to look at those missions in terms of proper programme work streams. And then finally, we get to a sustainable point where it's not about kind of waterfall step delivery, but we're getting into a point of sustainable kind of release management around service lines like 111 or 999, where we're continually iterating based on the outcome we need to deliver against, and we're releasing capability throughout the year. But as I say, there's a huge amount of complexity, and the real aim was that anybody in our organisation could get to a point where we could put everything onto one page and say we've got 5 principles to react, to change, 4 missions to drive it, and then we've got the 3 phases to deliver it. So that's how we got to this stage of the strategy. We're going to review it on an annual basis against our wider organisational strategy, and build upon it year on year, basically as an enduring plan about how we use technology to derive benefit for the people of Wales. So thanks very much. That's the end of my presentation.
Okay, it's 11:10, so welcome back, everybody. We seem to have held our audience from the first half of the session, which is great. So without further ado, I'm going to hand over to our third speaker for the day, Stephen Frith. And Stephen is the Programme Director for Digital Services for Patients and the Public programme. So Stephen, I'll hand over to you if I may.
Yeah, thanks very much, Bob. Hopefully people can hear me and see my first introduction slide. And today I can really only provide a high-level overview of the Digital Services for Patients and the Public programme, and those that have engaged with the programme and spoken to us will know that I'm happy to talk all day about this extremely exciting and timely programme. So if you do need to know more, do get in touch. There's contact details at the end of the presentation. Happy to engage directly with people that want to know more about the programme. The programme itself sits very much within the kind of this policy described in A Healthier Wales, and there were 2 things in that document that I wanted to kind of draw people's attention to, because policy and politicians talk about an online digital platform, but also an open platform approach that supports innovation and allows rapid development of digital services. So the programme sits in that policy context. That's what it's in place to address. And the programme team that's overseeing the delivery sits in the Digital Health and Care Wales, DHCW, delivery unit, and it's closely aligned to the NDR programme that the previous speakers spoke about. So that's where the programme sits, and the policy that it's in place to address. But before I dig into exactly what the programme is going to do, I thought I'd just do a little kind of thought experiment and use the Mentimeter to see how that goes, to help describe what we mean by digital services. So do bear with me. It's a bit of an experiment. It's not a scientific poll, but I thought it might be an interesting way to get a kind of collective view on what we mean when we talk about digital services in the health and social care environment. So if I can flick on to the Mentimeter slides, there are 10 quick questions that I'm intending to run through. So there we go. Yeah, it's there. So the first one: do you use a smart device, e.g. Fitbit, Apple Watch? Oh, great. People have downloaded Mentimeter. They're online and using it. So yeah, I don't know how many people have registered. We'll give it a couple of minutes on this first question, just so that people can get used to the technology and check that it's working. As I say, it's not a scientific exercise, this, so don't panic if you're desperately trying to get online and contribute, but I just thought it would be an interesting exercise to ask the question. So probably not unsurprising, quite a large proportion of people, assuming that we've got 36 people using the app and downloading results into Mentimeter. That looks about 2/3 use smart devices to monitor their aspects of their health and well-being. If we flick on to the next question, which is whether you use an app to check your bank account. Slightly left field this, but really I wanted to just illustrate the point that we use digital services in all aspects of life. Very high percentage, not surprisingly, use online services or applications to engage with banking services. And the reason I find this interesting is because on previous exercises where we've looked at health information, the sensitive nature of health information always comes to the fore. And yet we don't seem to have the same kind of nervousness about our financial information, and we've definitely moved to online financial services very quickly. Next question. Again, just to illustrate the level of engagement with online services. Oh, that's resounding 100% of the people in this very small poll quite happy to buy things online, and obviously don't find that the technology gets in the way of doing that. Next question. Now we start moving into health and well-being. So do you use Google to take a little look? You know, if you're feeling a bit peaky, do you do some online research? Yeah, I'm sure the clinicians and practitioners will not be surprised, but might be slightly concerned by the level of Google health management that is going on. Yeah, there we go. Sort of 90% of people have used online searches to find out about health and well-being. Next question. Do you have any devices at home for measuring your health? So blood pressure monitor device, or some kind of, I suppose even an Apple smartwatch, particularly the version 6 and version 7 of the Apple Watches, with some very sophisticated home measuring capabilities within them, collecting a phenomenal amount of data every single day about sleep patterns, for example. The point there being that quite often a lot of that data doesn't go anywhere. I myself have a blood pressure monitor. I check my blood pressure occasionally at home, but I don't do anything with it. It just sits in my head, my knowledge. And as you can see there, maybe 2/3 of people on joining in this exercise do the same. Next question. Oh, now booking appointments, engaging. So this is actually digital services for health. So using an app to book appointments in the NHS. Oh, it's dropping off. Oh dear, it started good. It started at 100%, but it's now down to about 30%. Yeah. So, and I would moot that the reason people don't do that isn't really that they don't want to. It's probably more that they're unable to in a lot of cases, and that's one of the issues that we need to address. There's a significant change management agenda within all of this. Next question. Oh, now this is it. Viewing part of your health record. I suspect very few people have done this, although people that have access to the NHS app in England may be able to see parts of their primary care record, but it's increasingly difficult to have visibility of information held within the NHS environment. Next question. Book repeat prescription. So this is now moving into transactions, not just viewing of information, but actually doing stuff, engaging without necessarily picking up the telephone, but using an app or an online service. So repeat prescription seems to be sort of low-hanging fruit in this space. It seems to be an area that digital services find slightly easier to conquer, and we do manage to do a slightly better job within the NHS of opening that up. But still here running at about what looks like, a bit of mental maths there, 60-70%. Next question. Waiting list. Where are you on the waiting list? You know, this is what everybody would like to know. I'm absolutely certain. And yet I'd be very surprised if many people have been able to do that, because the data is just not available. And yet that's exactly what we're talking about when we're talking about digital services in health and social care. Why on earth is it not possible for someone to view that data and see where they are in a waiting list? The NHS is all about queuing, and if you don't know where you are in the queue, that makes things very difficult. And I can't remember if there's any more questions. I've lost track. There were 10 questions. I should have numbered them. Online, to talk, yes. So we're moving beyond transactional now and into communication services. And interesting that people have actually had experience of this, and speaking to practitioners, it's amazing how many actually would welcome this kind of ability to have a much more direct relationship with the people that are in their care. So another example of a digital service in health and social care. And was that the last question there? Or yep, it was. Great. I shall steal the screen back again, go back to my presentation. So thank you for that slight indulgence. And what does that thought exercise show? Well, in some ways fairly predictable. Clearly a growth in interest in using home devices to monitor and record fitness levels, everything from Fitbits and pedometers to blood pressure monitors. But less digital engagement in health generally, and the NHS specifically, when it comes to transactions. And again, it's predictable, but it does raise the question: why should health fall behind areas such as insurance and banking and taxing your car? And I'm sure the people on the call know, commercial providers and practitioners, that it is hard. And one of the reasons why it's hard is because the data, well, there's two things about the data. One is it's just huge, and the other is it's sensitive. And when I say the data's huge, it's multi-organisational, it's segmented by care delivery processes, it's separated by process, it's built around processes and not people. So you've got a primary care process, you've got a secondary care process, and historically data has not transcended those boundaries particularly well. And as we move forward, it's increasingly segmented with primary secondary care community and third sectors, the private sector, and increasingly social care. So that segmentation of data will only get worse if we're not careful. So it's a large data set, it's a sensitive data set, and the challenges to opening it up are huge. But digital services is all about using that data to allow people to do service transformation and deliver new models of care. And the strategy in Wales is very much about opening up access to that data in a safe, secure fashion, and building patient engagement models that are much more digitally based. But how do we proceed? People that have seen the vision for digital services for patients and the public will have heard us talk about the core platform. And I was flattered actually to see one of my previous slides used by Allan when in his presentation talking about the strategies for Cardiff and Vale, and the strategy, the delivery model that I'm talking about here very much supports the kind of strategy that Allan has outlined, where there are just certain things that can be done to make it less hard to deploy digital services of the type that we were just talking about. And as a programme, we've grouped these loosely into 5 broad areas where we can just make rapid progress and make life a lot easier for people deploying digital services. In no particular order, we talk about a data and application interoperability layer. And I should say these core platform areas, we describe them as services, which is quite a good way, I think, to describe the way that we see them operating, in that they're something that's available for people to draw down and use as they need to. And the data interoperability service is probably, well, definitely the most complicated of those. It's simple to define at a high level, in that we've got a mountain of data residing within the collective NHS domain, across multiple systems, and the citizens operate in their domain, and we need to move data from the NHS domain to the citizen domain and back again and capture data in the citizen domain. So there's an interface and data has to go across that interface, and that's really where we're talking about the data interoperability service operating, using standards to allow people to move data across that boundary in a secure and auditable fashion, and to allow third-party developments to take place across that boundary. Learning really from the fact that over the past 2 or 3 years, as people have tried to deploy digital services, always they hit a boundary on what's called data integration. They need access to data from the NHS, and it's difficult to do that. It's difficult to know how to do it. It's not standards based, and there just needs to be a slicker service for doing that. And that needs to be based on the second of these areas, information governance. There needs to be clear rules as to what is and is not permissible, what the data can be used for, who's having access to the data, and we absolutely need to retain the trust of the citizens as we do this. So clear policy and clear instructions for meeting policy in an information governance service to make sure that people that access data across that data interoperability layer are doing so in a fashion that is compliant with the information governance policy. And then we move on to identity management, and there's two things that get conflated in identity management. There's the need to authenticate on a digital application, and we're pretty much all familiar with that, I think, in terms of providing a username, password, email address, fingerprint recognition to show that you are the person who you say you are when you access something through your telephone. But the second part in the NHS is a kind of an ID verification to verify that that person is the person they say they are, which in a purist world you'd only need to do once, but you may occasionally need to repeat to double check that you've still got the right person on the end of the service. But effectively it creates that one-time link between an authenticated individual with an application and the NHS data set through identifiers such as the NHS number, so that we all know we're talking about the same person and we're giving access to the right information to the right person. And again, every digital service that people try to deploy will need to do that. It doesn't make sense to invent solutions for that 100 times. You might as well do that once and offer it as a service and build on the services available in NHS England for the verification. The gateway application is a place to surface that ID management and to capture well, we're moving away from calling it a consent model. It's more of a data access control model that will be needed to underpin the citizen viewing and control of data, particularly data that they capture themselves and feed into this environment. But also the gateway application can provide a springboard and an onward link to trusted extension modules and third-party commercial services if they don't plug in directly into the interoperability layer. Both routes are conceptually possible. And finally, the fifth area, if we're all about supporting federated projects and innovation, we need to publish technical documentation, have a sandbox environment, and a place where people can set up projects and build services, test them, and ensure that they work. So all of those things make up the core platform. And interestingly, that can be done, and we're going to attempt to do that pretty rapidly over the next 12 months. But it doesn't actually add any value from a citizen's perspective. What it does is it allows someone to download an application, say they are who they are, and link to NHS data. But they then need to hop off into a value-adding service, and some of those will be built as part of the DSPP programme, but the majority of them will be set up and operated as joint venture projects, working with interested parties to bring on functionality that adds value and build out from that core platform, and effectively layer that functionality onto the core platform with different levels of integration. So some functionality will fully integrate into that kind of core platform service, and the user journey will be pretty much seamless. Others might be a little bit more clunky in the first instance, or might for good reason, require hopping off into a different service environment. And of course, there will be links to other services and applications. And I always mention 111, and we saw the presentation from the ambulance service and their plans in terms of digital strategy. And we do need to make sure that we are very much aligned to give a consistent user experience and user journey, separating the clear distinction between those in need of immediate care and looking for information about their healthcare from those wanting to engage with healthcare services and have access to information about their healthcare that's held within the NHS. So the first push will be to develop the core platform services, but in parallel, we will work with a number of projects to add value onto that core platform. And this isn't by no means the full extent of the vision, but it's a slightly different version of the picture that Allan had shown in his previous slide set, where some things will build on the core platform, building on top of the 5 services that I presented in the previous slide. Some sort of consolidated booking engine seems like a pretty sensible thing to put into that core platform and capture as part of that service. But building out from the core platform, there's a lot of functionality and projects around PROMs, obviously access to primary care information, and extending that health record into secondary care. These will all need to run as federated projects with interested parties to A, get access to the experience and skills in the wider service, and B, make sure that we consider properly the opportunity to use existing solutions already available in the marketplace and make sure that we're not just reinventing a wheel for the sake of it. This vision is all about supporting the kind of federated approach that Bob spoke about when talking about the newly launched Digital Health and Care Wales environment, and opening up the environment to innovation and making sure that we can progress in parallel, all on the same journey, but rapidly and with a degree of comfort and knowledge that it will come together, and specifically present, always keeping an eye on the citizen experience, ensuring that it's simple, effective, coherent and consistent, and not a confusing citizen experience. So that's how the model will grow and the core platform will build out. I'm not going to talk about that in much more detail because the detail, the prioritization of it, the order of events and which bits of functionality are run as discrete independent projects, etc., is still all up for grabs, and the governance structure controls the way that the program will develop, and that's why I said at the beginning I encourage people to reach out and get involved, whether suppliers or whether within the NHS environment or even social care environment. The program board basically commissions the activity of the project and has commissioned the establishment of the core platform and is currently prioritising 2 or 3 of the value added areas to take forwards, but the delivery is through a range of different options shown on the right hand side of this slide under the federated delivery section, with some of it built by long-term development partners, some health board or other agency-led modules, some procure existing solutions and some procure a new build. So the delivery model is not fixed depending on which particular area the programme focuses on. But all of this is under the assurance of 5 different assurance groups: the practitioner, public and patient, service transformation delivery, technical and an ethical and information governance assurance group. So there's a lot of touch points on the programme through that governance model. And then the final thing before I finish, in terms of setting up the core platform and driving the initial value adding functionality, we're going out to procure external expertise, and hopefully this isn't news to anybody, any of the suppliers on this call, because we spent 6 months trying to warm up the market and let the market know that this is coming. The procurement is actually due to go live on Friday, and in some ways we've kind of held off ever so slightly for this opportunity, just make sure we do a final sweep and last opportunity to let suppliers know that this is coming as an opportunity. And we're going out to procure 2 sets of specialist expertise, or 2 lots. with either one or two suppliers bidding for one or two lots. One is a digital application partner with the expertise to set up the gateway application and make sure that that is fit for purpose and available and scalable. But the larger contract will be with a technical development partner able to come in and set up the data interoperability service as a service, write the APIs, set up the DevOps environment and move that data, or start to set up the processes to move the data between the NHS domain and the citizen domain in a controlled fashion. So very high skilled health data technical services are required to do that. Plus also plugging into the kind of standards that would be needed, both standards for API development, but also for health messaging. So very specialist resource. And if suppliers are interested in that and they haven't already done so, they should register on Bravo through that link, which will be available in this slide set, and the instructions there on how to register with the dynamic purchasing system that's being used for underpinning that procurement. And finally, for people wanting to get in touch, there's the contact details of the key engagement leads within the programme team. And that's it. I think I'm pretty much on time to stop there. Thank you very much indeed.
Excellent, thank you, Stephen. And I think that kind of rounded off the three presentations in a really nice way, in the sense of sort of taking us through what two of our major organisations are doing around developing their strategies and approaches. But with Stephen's presentation about the DPSS programme, leading through to that, what difference is this going to make to me as a citizen or as a patient in terms of how I interface with healthcare. So I hope to all participants, you've found great value in those three presentations. I know that I have. Now, the aim now is that we will move into a Q&A session. I can see that we've had a number of questions coming through in the chat bar. So my aim is to sort of make sure I can scroll through those and pass those through to our speakers to respond to. One I can deal with very quickly, I think you've probably picked up from the chat bar that Helen already responded to, which was just a practical question from Elizabeth Davis in relation to whether the presentations, etc., would be available after the event, and Helen has responded that they will be in about a week's time when the event goes up on the website. So anything that you've seen today and that you want to refer back to, you should be able to do that. So I hope that's helpful for people. So if I can go back and take a look at the questions then that we've had through so far. I think the first one was from Martin Reed, Cardiff and the Vale University Health Board, ICU. And Martin was posing the question around, so he was disappointed the Cardiff medical training curriculum has no time assigned to informatics training. I don't know whether nursing training is more enlightened. Are we resigned to having informatics learning being only a postgraduate activity for health professionals? So I think a really important question there in terms of the extent to which we are bringing our workforce and the future workforce with us in terms of skills to operate in the digital world. With a different hat on, I've actually got a response to part of that question, which I might come back to in a moment as well. But just turning to our speakers, I don't know, Alan, first of all, whether there's any comment that you would want to make about that, and then Andy and Stephen, if anything you want to come in on.
Yeah, it's a very good question, Bob. It's tempting to just respond by saying, yes, of course, there should be informatics training. The problem, of course, is that as the breadth of what we get involved with in the health and care world continues to increase, and it increases in depth as well, it's quite difficult, I imagine, to tailor a curriculum that covers all bases. So I think some elements of the informatics world will need to remain a postgraduate subject. I think what I'd be encouraging more than anything else is an understanding of what data can be used for, how data is turned into information and knowledge. So I would be hoping that undergraduates are being trained to to recognise bad science when they see it, and to understand data properly. Now, some of that's probably already going on, and it's not badged as informatics. So, yeah, an interesting question, but I don't have a nice, easy answer for Martin, I'm afraid.
Thanks, Alan. I don't know if Andy or Stephen want to comment anything on that. It may not be within your sphere, and that's quite happy just to say. So Andy first, and I think Stephen's putting his hand up as well. Andy?
Yeah, I mean, it's a hugely important issue. I think and it's beyond staff as well. So I think it's, we need to be educating patients, staff, and digital professionals as well, in terms of what the new systems are, what the new technologies are coming, what skills they're going to require. And I think obviously the Topol review came out a couple of years ago now, but I still think we're really wrestling with what we need to do in that space. And I know we've had some initial conversations with Health Education Improvement Wales about actual clinicians and their sort of digital skill set, beyond just our team, and how do we build that into continuous professional development, because it, like we say, it's not just the training you get when the thing goes live with the floor walker, is it? It's 6 months down the line when the next release comes out and it's all changed again. So how do you build that into your working day? So yeah, I think just acknowledging, like Alan, is that it's a big challenge and something we need to pick up as part of the strategy, because if you don't use it, there's no value from it, is there?
Absolutely. Yeah. Thank you, Andy. And Stephen?
Yeah, I was just going to add that I think it's quite important that we get the horse before the cart with a lot of this, and the technology really is just an enabler. And I was actually going to make the point, or reinforce the point that Alan made, that actually all of this digital transformation requires service transformation ahead of it and in parallel with it. And I see the training as an essential part of that service transformation. The technology can only be put to good use if the design and the delivery models is appropriate to use it, and that can only happen if people are trained appropriately to make use of the digital services.
Okay, thank you, Stephen. That's helpful. I'll just add my 2 pennyworth actually onto the end of this one, because with a different hat on, I actually do some work with the University of South Wales, and have been involved with work around responding actually to Health Education Improvement Wales retendering of the educational contracts work, and it's quite clear from that and the specification that HEIW have put out, not just for nursing but for allied health professions, paramedics and others as well. This is not medicine, but it's the other health professions. That the development of the digital component of the curricula is really important and is beginning to become centre stage. So just with a different hat on, I've seen some work which is ongoing there, which I think is really acknowledging and being driven by HEIW in terms of educational providers. So I'm not sure how that's playing across into medicine, but that's certainly true from what I can see with the other professions. Okay, so I hope, Martin, that was at least a partial response to the question that you raised. The second question that I had, actually, Andy, was for you. It's from James Pechenik, and it was about the pilots on the 4 missions, Andy. So it was are the pilots for the 4 missions based on specific outcomes you are looking to achieve, and can you give any examples of those? And questions of, are you building the pilots in-house or via third parties with industry and unis? So is that clear enough? Did you catch that?
Yeah, absolutely. I think so. The intent of the pilots is that they'll be outcome based, but actually those outcomes won't be defined by the digital directorate. They'll be defined by the organisation or by other bodies or patient groups. So where we're at the minute is just starting the engagement around some of that, to look at each kind of overall outcome and work out what potentially what existing work sits within there, and how do we look at something that we might want to build out. So that could be the looking at things like respiratory pathway and use of wearables, but ultimately making sure it's kind of patient clinically led. So the challenge we've had up until now is obviously we've been at one of the highest resource escalation positions we've ever been in with COVID. So getting that staff buy-in is starting now. So I think it's outcome based, but it's making sure the right people are defining those outcomes as well, and that it's going to deliver sort of a tangible benefit that we can then build on and start to share out. So the other side of it is we'll start to work with kind of local government and other health providers as well, to make sure that we're kind of working together on those pilots to deliver some real value.
Excellent. Thanks, Andy and James. I hope that responds to the question that you put in the chat bar. The next question I have is from Errol Finkelstein, and it was initially framed at the end of the first two sessions as a question for the first two speakers, but I think possibly relates to Stephen's presentation as well, which was around, given the understandable strategies and caution new shiny things, how do we as a system go about seeking new solutions and technologies, possibly things we don't know about, at the time when we're seeking proposals to meet our priority needs? So it's a question, I think, externally, in the sense of how do you interact with the system? How do you bring forward innovation to ourselves in a helpful, structured way that's not dismissed as the latest fad? So it's an interesting one, and again, I reflect just in the first few months that I've been in this role. I think when people spot that you've got a position of potential authority in the system, you get phone calls and messages coming through saying, can I have a chat to you about whatever it is? And it's something that I've struggled with myself, I think, in terms of, well, where do I signpost this person into the system so that we don't go off down on a sort of an inappropriate conversation? So I don't know, Allan, Andy and Stephen, I'll go in that order. If you want to respond to that, so I think essentially a question about how do we embrace new ideas, and how do people from outside, how should they engage with us in terms of bringing new ideas forward? Allan, do you want to?
Yeah, sure. Key question, and one that exercises me and my colleagues a lot. We do want to embrace new solutions. We do like shiny things. But the trick is to try and make sure that we're doing them in a coordinated way. So the mechanisms that we're trying to set up locally are those programme management boards. So, but by the way that we've shaped our strategy, there's platform, patient channel, clinician channel, analyst channel capabilities. I can signpost most suppliers who've got something they would like to tell us about to one of those programme boards, and those programme boards are broad, they hold a conversation, they've got an understanding of the user needs in their area that's strategically aligned. That's the way to take the conversation forward, I think, in our own organisation. Events like this are very helpful. I hope it's helpful to suppliers to get an understanding and an insight into the challenges we're facing and the strategies that we're trying to adopt. Maybe one thing I would advise suppliers to avoid, so things that make it difficult. So it's tempting to say that are annoying, and they are annoying, but that's not important. They're annoying because they're difficult. If you go straight to the top, to the exec level, there's maybe a lack of that strategic understanding there in enough detail, and that top-down approach can start to become counterproductive. Likewise, if you engage directly with clinicians on the floor, there's again a danger that expectations can get out of control. So I think it's about just making the connections at an appropriate level in the organisation. But that's a problem for us as a system to address, because I don't think we've made it easy for suppliers, and suppliers end up going to execs or going direct to clinicians because there aren't any other routes available. But that's what we're trying to create locally.
Thank you, Allan. That's helpful, and it prompts me, in a sense, I think, to for conversations inside DHCW about how we have a common approach to this. So in a sense that people aren't confused about who to talk to, but also we don't get sort of bounced around between one another, or ideas don't get bounced around between one another and go nowhere if they're of real value. Andy, from your perspective?
I think it's a really good question. Yeah, I mean, so for me, I think a lot of the work is on us to put ourselves in the way of opportunity on this. So I think there's probably two strands of that. There's the kind of technical foundational element of having things ready to go off the shelf, like a common set of standards for cloud, for example, or having hyper-converged infrastructure that allows you to tier off to cloud in the same manner. Looking at our data, having it all available through the same set of APIs that people can pull in. So all the things ready, the building blocks to do these new and shiny things. So I think there's a whole set of work around kind of standards, policies, contract management as well. If we want to work on a pilot with somebody, have we got a set of IG policies ready to go? Have we got a zero value contract around an MOU that we can sign up to collectively to sort of make sure that if we get value out of that piece of work, we know where that's going to sit, what we're doing with the data. So there's a huge amount of bit around that. But then there's the other bit, which is beyond the digital piece of me, which is actually let's articulate the stuff that we really want to do. So that actually, when you see that solution, you can align it to the problem it's there to solve. Because I think sometimes there's a confusion there about, like you say, you don't know who to signpost to, and it's clearly between us understanding that, right, well, that aligns to this strand of a healthier Wales. Go talk to these people who are working on that program to deliver against it. So I think there's two things about kind of getting ourselves in a shape to be able to move when these opportunities come, but then also understanding what we want to employ them to do. So I think there's a lot of work of it on our side of things, but we are definitely interested in taking things forward at pace. It's just trying not to hamper ourselves in the process.
Excellent. Thanks, Andy. And Steve, do you want to make a final comment on this one?
Yeah, absolutely. So the DSPP model is very much about sort of building the technology for partner organisations to take forwards and deploy. Sorry, I think I might be answering the second question, actually. Let me just go back to the question list. Apologies for that, Bob. I don't want to launch into my answer to the question that I was just reading. Let me go back to the question. This was the one
in terms of how people outside engage with us, really, bringing forward new ideas and innovative ideas in a way that's constructive.
Yeah, absolutely. Sorry, it's the prioritisation question from our perspective. So the short answer to this is in terms of adding value. So we in the presentation I talked about setting up the core platform and then building out projects or establishing projects to add value onto that core platform. And we are at this very moment working with the programme boards to work out the prioritisation of those kind of secondary projects. And one of the key themes of that prioritisation is the ability to add value. So value in healthcare, specifically in areas like improving outpatient processes, reducing outpatient attendances, that kind of thing, where you can actually put a quantifiable figure on it. So that's kind of driving our prioritisation. But understandably, we're also steered by tactical needs of the moment and prioritisation around things like COVID, vaccine appointment bookings, and those kind of areas of functionality will come in and influence how we select what we do. But yeah, absolutely, the intention is to follow a published and structured approach to prioritising what gets taken forwards and in what order, so that we're not just chasing after, as Alan said, shiny new things.
Yeah, absolutely. Thank you, Stephen. And I'm just picking up from a message from Helen in our chat bar as well, that external companies, others are welcome to get in touch with colleagues in the ecosystem, because that's part of why it exists, in terms of working between the NHS and industry to try and help build relationships and partnerships and help signpost people in the right direction. So that is another avenue which is open to people as well. I'm conscious of time moving on. We've got a couple of more questions that I just try and get through if I can. The next one was from Niall Quilton from the NHS Wales Shared Services Partnership. And again, Stephen, this one's really a DSPP related question, being it would be helpful to explore if the DSPP model can be applied to the back office services and systems that NHS Wales Shared Services Partnership deliver, not necessarily to patients, but to NHS organisations, primary care and so on.
Yeah, sure. And in actual fact, that was the question that I was embarking on answering. So yeah, I'm happy to take this one offline to a large extent. And if you want to get in touch, Niall, I'll explore that, because definitely interested in that. But the short answer is that anything that resurfaces the information and knowledge that's captured through the DSPP environment slots into the NDR, and the NDR is our route to resurface that information in the clinical and NHS environment. It's set up specifically to do that, so that we're joined up and can focus on what is already a large and difficult area in the citizen sphere, and let the NDR do what it's set up to do in the clinical sphere. But happy
Thank
to take
you.
conversations
But
forward.
happy to take that offline, which is helpful. Thank you. And then I've got a comment stroke question, I think, from Paul Soloway from Hull University Health Board, reflecting, I think, on Alan's presentation. That some of Alan's earlier remarks were reflecting on issues raised a number of years ago in the various reports, like the PAC report, the WAO report, which was about how can we affect the change needed nationally when we are still procuring large national systems which take years to deploy, and health boards line up in a deployment roadmap and wait, pharmacy, intensive care being a couple of examples. So often these solutions are long contracts, which means solutions become out of date before they're employed, and that's something I put my hand up and say I recognise in a former role, in a former life. I was quite heavily involved in the LIMS project, Laboratory Information Management System. It's just a good example, and it's a conversation I've had with colleagues across DHCW in recent weeks, this business about how you move from a kind of a sequential approach to doing things to a kind of an in parallel approach to doing things, or indeed, creating a completely different model in terms of the way that we develop we develop our solutions in the long run. So I think it refers to some of the sort of legacy issues that I indicated in my opening remarks today. But I don't know if colleagues, speakers, Alan, Andy, Stephen, if there's anything you would like to add to that, because I think it is pointing to one of the big shifts that we need to make as we try and find a new model working forward. Andy, put your hand up, and Alan.
Yeah, I was just going to say, it kind of relates to, I think there's definitely a thing about the approach there where it's appropriate, like you're saying, and something that potentially the centre or kind of joint groups can help with. So my sort of first role within health was working on the transition from the N3 network to health and social care network, which is the kind of new underpinning network across the border that we link into in Wales. And the approach from that was to shift away from kind of a large single monolithic contract to a framework of suppliers that were all effectively had a kite mark to say they were available to supply that kind of technology, and then the individual entity goes off and buys that, and actually devolving through a common set of standards and policies the responsibility and accountability down to the local body, funding where appropriate. But I think where it's right, I think creating a framework to allow people to innovate and own the delivery themselves is probably the way forward, to allow that federated approach, because otherwise you do get to that point sometimes of having to wait for everybody to get on the bus, at which point the people who got on there first have changed their requirement. So it's not fit for everything, but I think the approach is definitely critical to it.
Thanks, Andy. Alan, did you still want to comment?
Yeah, I mean, that's extremely well put. The only thing I would add to that is I remember through DHCW hearing about a really good example of that way of working, which we're trying to mirror from Royal Mail. It was a couple of years ago, I think, at a DHCW presentation, where the description was how Royal Mail realised they had this platform of data, and that by opening up APIs to that data, you could make some APIs open to only internally to certain departments within Royal Mail, other APIs open to partners of Royal Mail to link their systems in, and some APIs just for anyone open to the public. The change that was brought about was transformational, because those APIs were made available for all that innovation to take place, and you no longer have to control that innovation from the centre. It happens in a way that you could never manage yourself, and I think that's the model that we're trying to aspire to get to. Excellent,
thank you, Alan. And I think Stephen, you just want to comment as well?
Yeah, just very briefly. It's I think it's a good question, point well made, and I think it would be remiss not to mention that the NDR and the programme has been set up specifically to address this kind of point. There's an exact synergy between the presentation I gave and the technical architecture we're putting in place for patient-facing digital services, with that movement of data from the citizen environment to the NHS environment and back again through a structured, controlled interface layer to what the NDR is trying to do. And without that, you can't have the kind of innovation that Alan's talking about, but with it, you can, and then people can go and buy best of breed, and you can have a free market for the functionality that people want to buy on top of that data interoperability layer. So that's exactly what the NDR attempting to do so. So hopefully things will improve pretty rapidly over the coming months and years, and some of the frustration that's implied in Paul's question will hopefully, the tension will be released a bit.
Thank you, Stephen. We've got a couple more questions, comments. I'm just going to try and get through one or two more of those if I'm able to before we're out of time. There was another question from James Pachenik, which was actually, Stephen, again, maybe something to be dealt with offline, but it was a question about the DPSS program. It said, I believe in order to join lot 2 on the DPS, you have to have a product that has a roadmap attached to it, which sounds like a product-centric procurement rather than a digital technical development partner. Quick response or deal offline?
Well, I'll just do 30 seconds on it, if I may, Bob, just because it's come up before and we are time sensitive on registering the DPS. I mean, the long answer is you'd have to understand the public sector procurement regulations and what a dynamic purchasing system is and the framework nature of procurement. But the short answer is, if the procurement vehicle has a mandatory question, yes, no, and you have to say yes to be within the procurement, I would advise suppliers to answer yes and then work out what a product roadmap looks like. It's because we're using the DPS to procure services, and the people that set up the DPS a couple of years ago put in a question about a product roadmap, which is, as you've pointed out, slightly less applicable to our procurement. But you need to answer yes to that question, have a product roadmap, even if it's a side of A4, get into the procurement, and then see if the procurement is appropriate for you when you see the documentation.
Lovely. Thank you, Stephen. That's very, very helpful. I think one sort of final comment, there was a comment from Elizabeth Davis from HSS Delivery, which relates to, I think, the earlier question about skilling up staff. It was just a comment to note that the outpatient transformation programme is driving digital approaches in the service delivery model, and we are looking to engage with HEIW and universities to look at training needs in delivering virtual healthcare models. I can see there's a couple of other comments, questions in there which have come through, and I'm going to have to apologise to people who've raised those, that we haven't got time to take them now, but what we will do is try and make sure that we get a response to you offline into any other questions that I've not had the time to cover, because I'm conscious we're coming right up against our midday deadline now. So I'm going to effectively bring the event to a close. I'd just like to thank, on everybody's behalf, our 3 speakers, Allan, Andy and Stephen, and colleagues in the digital ecosystem who have put this event together today, and of course all those of you who have participated and stayed with us through the 2 hours. Grateful for your time today. I hope you've learned a great deal from the session. I certainly have, and I would look forward, or we would look forward, to inviting you to further events from the digital health ecosystem in the future. So without further ado, I will close the event and say thank you to all of you for participating, and enjoy the rest of your day. Thanks very much, everybody.
Cheers.
Thanks all.
Thank you.